Hey, good afternoon. Brian Saints here with Abbott is here.
Okay, great. Now we can start.
Sorry about that.
That's okay. Good afternoon, everyone. Thank you for joining us for our weekly Zoom call. My name is Melinda Skirvin, and I am the Divisional Vice President for Five Star Senior Living and Board Chair for Florida Senior Living Association. Let me just give you this week's latest COVID numbers. They're good again. 2022 residents, that's down 932 from last week. And staff numbers this week are 3,273, down 454 from last week. So we're making lots of progress, keeping those numbers at a low level in our communities. So please continue to be diligent and watch for any signs and symptoms both in your residents and your staff. Jason, can you give us a quick update on last week's long-term provider conference call?
Yes, thank you, Melinda. So from last week's industry partner call, again, we are seeing the continued stabilization of the numbers. The positivity rate is flirting between 3 and 6%. We have seen a 55% reduction in residents and staff since July. That was at the peak, so we're down 55%, both residents and staff. I did want to point out, we did hear during the call reinforcement that communities can limit visits in order to support necessary staff for screening and monitoring adherence to masks and social distancing. So just be aware of that little nuance. A few other things we heard is that AHCA is lowering the number of the isolation facilities that are out there. These are the step up or these step down facilities. They should be lowering in the middle of this month and again at the end of October. Now, this does pertain to AHCA's agreement itself to fund or have beds, but it does not preclude communities from still using these isolation facilities. Only one exception is the Miami Care Center. That one's not going to be able to accept any further admissions. And also one other thing that they wanted to remind everybody as well is that hospitals are still bound by the emergency rule that requires anyone who is being discharged from a long-term to a long-term care facility with an unknown status to have a COVID-19 test within 48 hours of the discharge. You know, these residents can be returned to the community before the results are back, and if that happens, just treat them as unknown status per CDC guidelines until the results come back in. Again, they are not required to do the repeat testing or the 2 negative tests separated by 24 hours as we've moved to the symptom-based approach. Also, the Abbott test kits, you'll be hearing more of this in a little while. They are being shipped out. There should be about 540,000 to ALS under the CLIA waiver. And I did want to provide 2 other notes. This wasn't in the industry partner call, but just FYIs. One of them is the CDC updated their overview of testing for COVID-19. This was made back on September 18th. And the summary of it is due to the significance of asymptomatic and pre-symptomatic transmission, their guidance has further reinforced the need of when to test asymptomatic persons, including close contacts with a person who's documented to have it. You'll see the link for this at the end of our presentation in case you missed it slide. And finally, one thing I wanted to point out to everybody, we put this out in our FSLA COVID update number 52. We prepared a issue brief to speak for whether residents that leave a community need to be quarantined upon their return. The short answer is that communities cannot prohibit residents from leaving a community. However, upon their return, they have to be screened, and per the emergency order, if they fail that screening, they can't come back in. Even that aside, though, the communities do need to make a case-by-case decision whether the residents do need to be quarantined, and this is based on the risk of exposure that they incurred while they were out. Is their status effectively unknown? And keeping in mind that if residents do start testing positive in a community, the agency might write the community up for failure to protect the residents' right. So when making your business decision, keep those 2 nuances in mind. Thank you very much.
All right, thank you, Jason. We are so proud to welcome Brian St. Cyr from Abbott Testing. Brian is the National Director of the U.S. Commercial Lead for Binax. Now, the HHS rapid test rollout. Brian oversees 8 executives and has worked with Abbott for the past 13 years. Welcome, Brian. Also joining us as a panelist this afternoon is Charlie Dierka, Executive Director with Countryside Lakes, and welcome, Charlie. Go ahead, Brian.
Thank you very much. Yeah, so again, I'm Brian Sainter. I'm the National Sales Director with Abbott and the U.S. Commercial Lead for the rollout of the BinaxNOW antigen card. And I was asked to join the call just to kind of for an open forum to see what questions you guys may have. I know a number of you have probably received some BinaxNOW COVID cards, and just here to answer any questions or concerns. So I'll open it up to the group.
Brian, before you get started, this is Sandy with Florida Senior Living. If you could give us a little bit of background about Abbott, how you guys were chosen to be the vendor for the test, just kind of what's, you know, what preceded this process before we started using Abbott Test. That would give us some good background information.
Yeah, absolutely. So if you guys are not familiar, Abbott Laboratories is the #1 diagnostic company in the world. You know, from the onset of the COVID pandemic back in, late February, March, Abbott has released, I believe now it's 6 COVID tests to the U.S. healthcare market, as well as outside of the U.S. We've got from molecular COVID tests on our large platforms like Alinity, to antibody tests on our large Architect instrument, to more point of care type molecular assays on our ID Now and our M2000 instrument, and most recently the launch of our BinaxNOW COVID antigen card, which is a lateral flow visually read card. Really, I think the reason you guys are starting to see these, this is the first antigen test that can be mass produced. And when I say mass produced, we have the capability of producing around 50 million plus tests per month. And it's we've launched this to the U.S. market at a very, very low price point of $5. So, this is something that we're making available, kind of outside of what we consider that traditional healthcare market for us, which is that hospital, physician office, lab, urgent care type of space, and going outside of that into the long-term care market, the employer market, the education market, both K through 12, as well as higher education. And we understand that there's not some big pool of money that everybody has to throw at COVID testing. So we put a very low price point on it to make it affordable and accessible to the folks that typically wouldn't be able to get their hands on a COVID test. The reason you guys have received it is shortly after we received our EUA, our Emergency Use Authorization from the FDA, the federal government, our Health and Human Services, did sign a contract with Abbott to purchase 150 million tests. That is all of the tests we can manufacture pretty much through the end of the year. So we're essentially selling our tests to the government, and then the government is telling us, here's where you send the tests. So, my team is involved in that rollout, as well as support for that HHS rollout strategy. And the long-term care space is one of the spaces where HHS determined was a necessity to get this product out to quickly. So you are one of, the folks on the call that have received kits are one of the first to receive this kit in the world. These are our first shipments that are going out. So that's why you guys have them today.
Awesome. I know that Charlie has joined us. Charlie, are you able to unmute? And let's see if we can get your video on. We've got sound from Charlie. I know, Charlie, you wanted to walk through a couple of different questions with Brian. If you want to go ahead and work on those with him.
I sure could. I appreciate you taking the time with us today. I received about 80 tests. I have 120 employees, so that's going to leave me a little bit short on my first round of tests. But I spoke with the Volusia County, where I'm located, health department today, and they informed me that I would have to have tests for my residents as well. Can you confirm that?
Sure. So we, Abbott has not, that HHS is determining how many kits are being sent out and who you're supposed to test. That's, we're just simply the manufacturer of the product. So HHS is guiding us saying, hey, send 2 kits to your facility and 5 kits to this facility. My understanding is that the first round of kits that were sent out were specific for staff testing. As far as resident testing, you would obviously need more kits to do that. We are working closely with HHS, and our current goal is to, HHS is building a state-by-state contact list for myself as well as my team, so that we have someone at the state level that we can reach out to with questions like these, because we don't, unfortunately, we just, as the manufacturer, we don't have that answer at this point. We hope to be able to provide some guidance to you for questions like this in the form of a state contact that's kind of managing that state-by-state rollout. We just don't have that yet. Unfortunately, with these HHS rollouts, it's they buy a bunch of product and then they start shipping them everywhere, and we're all kind of scrambling, trying to pick up the pieces. So I hope to have more guidance soon. I just don't have it yet.
Oh, Charlie, you're on mute, Charlie. We're not hearing what you're saying. Sorry about that.
Sorry, trying again. Is that better?
Yep.
Okay. I sent an email out to the website provided that was supposed to allow me to get more tests, but I was told by my health department that, or actually by a rep at Abbott, that ordering more tests would be up to the federal government whether or not I was approved to get more tests.
That's
Again,
correct.
something else.
So,
I mean, that just kind of makes me a little nervous with the timeliness of the federal government being involved.
yeah. So I think the form you probably filled out was the lead form, or interest in the product. If you went to an Abbott webpage and filled out a form, basically what that is for the general public, for your folks that do not have kits or haven't gotten kits, just to put in a lead form, if you will, to notify us so that we can reach out and explain to them that HHS has purchased all of our product through the end of the year. The only way anyone can procure kits is to work with work with the federal government to get kits. So that form you filled out will not trigger any more kits to get sent your way. You would have to work with with your state to procure more kits. And unfortunately, that kind of leads back to what I mentioned a minute ago, which is we currently don't have any direction on where you need to go to procure more kits. We're waiting on that information from HHS.
Okay, and I mean, that being the case, most of the questions I really have left are for my local health department. So at this point, I'll kind of relinquish back to the panel.
Yep.
Thank you, Charlie. Those are some good questions, and thank you, Brian, for helping us understand some of what's going on. It sounds like you guys are getting a ship these to this place list, and we're just kind of making it work from there. We do have a couple other, it's federal government, guys.
Well, I know Charlie had a question too about the percentage of positive rates in his county. Brian, do you have any idea about that you can talk about just a little bit?
I'm sorry, can you repeat that question?
Sure. In our state order about the testing, it talks about the time frame that you have to test staff. And Charlie, you want to go through the question real quick so Brian understands and maybe he can answer that question for us?
Sure, absolutely. If you have over 10%, which Volusia County's 11.3 positivity rate, that triggers through the CDC and through our health department that we will need to be tested twice a week. And if you're testing 120 employees and 120 residents, that's roughly about 60 hours of testing for the first round and about 60 hours of testing for the second round. So that pretty much eats up just about your whole week in testing alone. So it's just it's going to be a little bit of a challenge for us for sure.
Sure. Yeah. So as far as the prevalence, within your community and the protocols that are being implemented by your Department of Health and the state, that is different. Obviously each state is run differently. So that is going to be, whether all of the states are following the CDC guidelines, I don't know the answer to that. I'm not close enough to each individual state. But what you said makes sense. What I would tell you is when you're thinking about the testing itself, the procedure, this BinaxNOW card is not run on an instrument where you're going to tie up each test for 15 minutes. You can have 40 of these cards laid out on a counter, all running at the same time. So when you do the math on the amount of testing, yes, if you add up those numbers and multiply it by 15, you're going to get to 60 hours. But just keep in mind, you can have multiple tests, 10, 15, 20, 25 tests all lined up on the counter going at the same time because they're visually read tests. When the timer goes off for that test, you read it and you're done with that test. You move to the next one, which is what we kind of call batch testing, right? You can do batch testing with the BinaxNOW. Does that make sense?
Yeah, that
Yes,
sounds
it does.
good, Brian.
All right, we've got a couple other questions coming in, and some of these, to be fair, Brian, they may be more questions for the local health folks. So feel free to say pass if you need to. We might have to have the health folks on maybe even next week to help us kind of parse this piece out. But we've got someone who's asked, as more ALFs receive approval for CLIA waivers, do you think more Abbott tests will be shipped in the future? So any thought on that?
Yeah, again, I think I would have to direct that to HHS, right? I mean, we're going to continue. We are manufacturing at full capacity and we're pumping out millions of kits, right?
Right.
Or millions of tests. But to the point earlier, we are shipping them to wherever HHS tells us to ship them. I mean, I don't even find out where they're going until they've already shipped. I get a ship to report at the end of the day and it says, here's where all of the kits have shipped. In the United States. So at this point, we don't have any, any way to influence where the kits are going. It's just simply HHS saying ship kits here. And that's where we're kind of limited right now. So I don't have an answer to, the question, if, will you get more kits? I'm not sure. I think once I have that state contact for Florida, at that point, we should be able to at least have a contact we can work with at the state level to put in requests for kits. I just don't have that yet.
Gotcha. Okay, that's fair. Any information that you can provide to us on who we are supposed to test? Are these tests supposed to be used for people who are symptomatic, or is this supposed to be a regular testing device?
Sure. So, when you think about COVID diagnostic testing, there is no test out there that is really designed for testing asymptomatic patients, right? Diagnostic tests in general are not screening tests. They all have, ICD-10 codes that symptomatic codes for billing. And so, this pandemic presents a whole nother challenge from a diagnostic standpoint because we know that we need to test asymptomatic people, but nobody has a claim for it.
Right.
So what I will say is, per our package insert, it does state that patients have to be symptomatic within the prior 7 days. The reason the package insert states that is because the sensitivity and specificity in the package insert were calculated based on clinical trials around that population. Patients that were symptomatic in the past 7 days. Now, does the test work on asymptomatic patients? No one knows. There's no data out there that says, You know, you can run a diagnostic test that's on the market today that's EUA approved on asymptomatic patients, and it's going to have a sensitivity of X. The data just doesn't exist. What I can tell you is two things. Number one, we are going into clinical trials on asymptomatic patients. Now, to complete that trial, it is going to take time because we have to test a lot of people to be able to find positives in an asymptomatic group. You guys can imagine, you know, going to a school, you test 1,000 students, maybe 2% have COVID. And a lot of those may be symptomatic, right? So just identifying those positives from asymptomatic individuals is difficult. So that takes time. Second thing I will tell you is based on the guidance from HHS and the PrEP Act, and happy to send you guys the link on this, they have stated that they are going to allow off-label use for healthcare providers to test asymptomatic patients in congregate facilities. So where you have people congregating, long-term care, nursing homes, schools, you know, employers, they are allowing off-label use. Now, again, we don't have data to support it. We don't know how sensitive the test is, but we do know that, or we believe that the more often you test, even if the test is less sensitive on that population, the more often you test, the better, right? If you test somebody every other day with a test that's 60% sensitive, it's still better than testing somebody once a month that's when the test is 99% sensitive, because you don't know what happens in between tests. You have a higher, you know, chance of catching that person if you're testing them every other day, even if the test is less sensitive. So that's kind of what we know today. I hope that answers the question.
Excellent. Thank you very much, Brian. And this may be a question for the FSLA folks on the phone, because we, you know, as Charlie mentioned, there's specific testing requirements depending on communities, but could FSLA clarify for the folks on the phone, are ALFs required to meet those testing requirements, or is that specific to nursing homes? And that's probably a question for Gail and Jason.
Jason, you want to take that question?
Hello, Jason.
Hey, Jason.
Hi. Yeah, from what we've heard, the CMS guidance is applicable only to nursing homes. However, we know ALFs with a CLIA waiver are eligible to get some of the get some of these tests. So one thing that we may need to get more specific information on is, does receive these tests trigger guidelines that may not normally apply? But by and large, the traditional CMS, the requirement that all staffs staff be tested, et cetera, that traditionally is going to be for the nursing homes only.
You know, and I think too, Brian, you bring up a lot of good information about, you know, the state contacts, how to manage the rollout. So it sounds to me like we need to get back with AHCA and also the Department of Health and maybe even the Emergency Management Office to find out how they want us to handle these tests. How long are the tests good for? Because if we need to wait to do the testing until we find out more information, or if we, you know, need to send them back or you know, throw them out, how long are the tests good for though before they need to request additional tests maybe?
Sure. So the tests are good at room temperature storage, and the expiration date on the kit is 6 months. I'm looking at my kit right now. 6 months from date of manufacture at launch. So that's what the current expiration date is. We are working on validity studies to extend that, but you can't do that until you actually launch the test, and you can start to test how long they're good for. So over time, it will get extended, but at launch, it's 6 months.
All right, that's good. And it's nice to know that they can be stored, they're shelf stable at room temperature.
Yeah.
That's very good to know. I imagine people are happy to hear about that. Let's see. So yeah, so a lot of the questions that we've been getting, you were able to go over for us the whole use within 7 days of symptoms, whereas HHS had mentioned maybe using it as a screening tool. So it sounds like there's a little bit of a discrepancy there that we might need to help our folks run down. The rest of the questions that we have right now, we've got a question about how to apply for a CLIA waiver, and we can get that information out to our members after this call. But there's a hyperlink on ACA's webpage, but it looks like it might be giving some people some trouble. I was able to Google Florida ACA CLIA waiver, and it took me straight to ACA's page that explained all the information. So if you wanted to go look at it right now, you certainly can, or we can send it to you when this call is over as part of our post-call summary materials. So we've got that information we can send to you. And then we also have a question in the chat about dining rooms. And it's a question that I know comes up fairly often, just asking, what can we do about dining rooms? And Jason had dropped a message back to everybody in the chat window. But Jason, do you want to go ahead and just walk through that answer again about the dining rooms? Because I know it's something that probably comes up on a fairly regular basis for all of our folks.
Yeah, no, I think that's a great question, and I'll give kind of say two answers here.
Typical lawyer approach, but that's fine.
I was trained in law school that the answer to every question is yes, no, and it depends. But the most recent guidance we have from ACA is, and I'll quote from here, as outlined in the CDC guidance, ALFs may allow residents to have meals in a shared dining room as long as the facility adheres to proper social distancing. This would only be permissible for residents who are not positive for COVID-19, are not a PUI, and have no signs or symptoms of COVID-19. Please refer to the CDC guidance for additional instruction. So that's the answer from ACA of yes, you can do it. You just have to follow proper social distancing, et cetera. And Florida Senior Living in Rapid Communication number 4, we actually did an article on a communal dining review that had some more links to guidance and explained it. The practical problem that our members may be seeing, especially our communities with a lot of residents for a smaller dining room, is the time it takes, even with this, just to coordinate through a meal. It may take an inordinate amount of time. So even though you might be allowed to do the communal dining with the proper social distancing, et cetera, it may not be that feasible. So that's going to be a real world problem that our communities are going to have regarding who goes to dining, who doesn't, who do they bring the meals to. So it is allowed, but it might be a little bit pragmatically a little difficult for some communities.
All right.
Yeah, and one thing I can add to that, because it sounds like there's two pieces to that, right? You have your social distancing piece, and you also have your, residents have to be, negative for COVID. Abbott did design with our Binax Now COVID card an application. Now, I don't know what the percentage of your residents have access to a smartphone or a tablet, but for the folks that do have an iPhone or an Android, an iPhone or an iPad or an Android phone or tablet, there is an app they can download called Navica. And what that app does is it allows the resident to fill out a short customer or a short consumer profile, is what we call it, or a resident profile. And they would take that profile with them to the testing location on your site. At the testing location, you would have what we call the administrator Navica app. Again, it's just an app. The way the program works is the resident would show the testing administrator their profile on their phone, which is essentially a QR code. The administrator would scan that QR code. It would then prompt them to start running the Binax card. That process starts with the administrator of the test actually scanning a QR code on the front of the Binax card. What that does is it links that card. So again, imagine you've got 20 cards lined up on the table. It would link that card to that resident. You would then perform the test. The resident can go about their day. Once the test is complete, 15 minutes, you would rescan with your administrator app, rescan that QR code on the front of the Binax card, and then it will prompt you to enter the result. You would enter positive or negative. Once you submit it, it automatically notifies that resident on their phone or tablet of their result. And it also gives them, if they're negative, it gives them what we call a digital passport. That digital passport can be used for access, for controlling access to certain facilities around the nursing home or long-term care facility. What it is in the app, they pull up their digital passport, and again, it's a QR code. And when they go to, let's say, the cafeteria, if you had an administrator at the cafeteria with the administrator app, they could scan that passport and it would verify that they've tested negative for COVID and whatever the parameters you set. Let's call it the last 7 days. So again, I don't know if that's something you guys could utilize, but it is a free app, both on the consumer side and the administrator side. And it just helps you kind of manage not only the workflow of the testing, but the communication of results and then the access to the different facilities around your institution. So I hope I did it. I usually have a PowerPoint and I show you what I'm talking about. So I hope I did that well enough so you could understand it over the phone.
Sure. No, that's very helpful. Brian, can you tell us how we get a username for the administrator app? And
Sure.
As part of that question, do you have to search for Navica administrator, Navica resident, or does it just know, or?
Yeah, so if you go into the iTunes store or the Google Play Store, you just search for Navica. There's a Navica with a blue icon. That's considered our consumer version. That's the person that wants to get a test done. Then there's an orange icon, which is the administrator app. That's the one that your testing administration would use.
Okay.
You can't just download them and get going. We have to manually get you set up with administrators and passwords and all of that. If it's something that that the system would be interested in, what I would do is connect you guys with Dave Kowalski. He's our global marketing manager who's kind of managing this Navica launch in the U.S.
Mm-hmm.
He can do an actual demo and show you guys how it works. And if it's something you want to implement, we could move forward with an implementation and training, site by site.
So that might be something, Gail, we just need to put a pin in and come back to. Maybe we can host a demo for our members who might be interested. Because it sounds like just in the chats that there are a couple people who are interested.
Brian,
Yeah.
I think some of that is in the PowerPoint from the call that Abbott held last Friday. Is that correct?
It was, yeah, Navica. It's something that we're offering to everybody that's getting Binax kits. It really is a cool solution that's free, and it really does help out for the folks that are not used to doing COVID testing. It's a perfect tool for kind of helping you manage the testing aspect of COVID.
Well, I think it's a great idea for folks to be able to move more, readily around the community as well. If they're showing negative, then that should be helpful.
Yeah,
How do you
and you
spell
think,
that, Brian,
really
without being asked?
Yeah, yeah, in any application, right? Think about a school that needs students that are trying to go to football games, having that pass. It works in so many applications outside of that healthcare space where people congregate. It's a really, really neat tool.
And is
So
it
Brian, I know you said that, I'm sorry, Sandy.
No,
I know
that's
you
okay.
said this contract was only through the end of the year. Do you anticipate that it may be extended into 2021?
Yeah, it's a great question. So our plan, what we know today, and our plan is that we will commercially launch this product in early end of December, early January, meaning the government wouldn't buy anymore. Per the contract with the government, they do have the ability to purchase another, round of testing when they deplete these. So I don't have a direct answer for you. I don't know what they will do, but they do have that ability. Yes, they have the ability to purchase more.
Okay, that's great. We'll stay on top of it.
And Brian, can you tell us, so do we know, and you may have mentioned this already, but someone just dropped it in chat, who is paying for the kits, or how are the kits paid for? Do you know? Yeah,
the federal government is paying for the kit. So you will receive a shipping invoice when you get your kits. It will have a dollar amount on there. The tests are $5 a piece or $200 for a kit. So if you had one kit sent to you, you'll see a price of $200. But if you notice on that invoice, it will say bill to, and it's going to have like troop something, DLA troops. It's part of the federal government. So they actually pick up the cost of the kits.
Okay.
There's nothing
And
you
so,
need to do with that.
Gotcha. And like you said, that's on the order, that's on the order confirmation form, just, you know,
Correct.
okay, perfect. We've got a question here if and I'm assuming that your answer to this is probably going to be yes, but do you foresee these Naviga cards or apps kind of being the future where everybody walks around with their digital passport? Do you think that's kind of where we're headed? Just out of curiosity.
It's why we designed it. So that's the thought. You know, who knows how it will take off or how long this lasts. There's so many unknowns. But yes, I mean, the plan is, it's eventually to get to that point where if that's where this COVID kind of drives the population to having to prove you're not positive for COVID, that it would be an ideal app. I think once we have the vaccines and we have, more clear treatment, and, I foresee this being, similar to the flu, but, only time will tell. It's a great idea and a great app for what it's designed for now. A year from now, who knows what that'll look like.
Gotcha. And you spell it N as in Nancy, A, V as in Victor, I, C as in Charlie, A?
You got it.
All right, good deal. Let's see. And Christina had asked, we're testing residents and staff. And I think, Brian, you'd mentioned earlier in the call, just to reiterate that the first round was intended to test staff. And hopefully if more tests are needed, the HHS would send you more kits, but that was the initial intent of that first round, correct?
That's my understanding. That was the direction that the Colonel Mole, who is basically the general run or the colonel running this whole show for HHS, that was his direction to us, was that the first kits were for staff testing.
All right, excellent. I think at this point we have, let me look at our Q&A. Erica had asked, how was it decided the number of tests each community received? Erica, it sounds like just based on what Brian is telling us that HHS somehow made that determination. We're not exactly sure exactly what the special algorithm is that they're using, but they're the ones who made that decision. And that's really all we know at this particular point.
That's all we know at this
point. Sorry. It's the government. They came in to help. And Beth Ann had asked if we can send around the information on opening the dining room. So it sounds like we should probably include that in our post-call summary, that information on the dining room. It looks like, let me just double check, but I think that may have caught us up on our questions for the for Q&A and in chat right now. Let me just double check that.
Well, Brian, we can't thank you enough for being on the call this afternoon.
Absolutely, not a problem. What did you say? What's the name of the overarching organization? It's Florida.
It's the Florida Senior Living Association.
Mm-hmm.
Senior. And how many facilities do you guys have?
We represent about 450 senior living communities.
Okay,
but just FYI, we did invite non-members to attend this call as well today. And we had, Sandy, how many registrants for the call?
Right now, we've got about 75 folks on the call with us, but we have about 134 who requested registration access.
We also had a Facebook page post as well. So we know it's being broadcast out there to the masses, Brian.
Yeah, got it.
All right, well, it looks like right now we're caught up on our questions and Q&A and in chat. So I will turn this back over to you guys, and you just tell me which slide to advance to next, because that's my job here.
Thank you so much, Brian. Gail, how about an update on visitation?
Great. Thank you, Melinda. We've been having regular calls with the AHCA secretary and the DOEA secretary, the ombudsman, and other associations for a couple of weeks now regarding visitation. At this time, we are learning that CMS guidance is differing with Florida's executive order in several areas. The first one is the number of visitors. So CMS does not restrict the number of visitors that can come and visit into your community, while Florida does have those restrictions for essential caregivers, compassionate caregivers, and also for general visitation. CMS does not restrict outdoor visitations regardless of the positivity rates, where here in Florida right now, you must be 14 days free of community onset, and there is a limitation on the number of visitors that you can have outside. CMS doesn't recognize essential caregivers. They have lumped everything into compassionate caregivers without any restrictions. The AHCA secretary has a call this evening with the governor to discuss all of these changes, because right now CMS is telling the state that what their rules are is what needs to go. So that definitely conflicts with what Florida has going on right now, especially for the compassionate care and the essential caregiver. I don't think that's going to go away in the assisted living communities, but there's a possibility that they may decide not to have the essential caregivers in nursing homes. It all really depends on how that call with the governor goes tonight. So guys, stay tuned. AHCA said they promised they're going to send out some new information as soon as the governor makes a decision about how we move forward with the conflicts with CMS in Florida.
All right. Well, thank you very much for that information. I appreciate that, Gail. Jason, do you have your "in case you missed it" slide ready?
Yes, ma'am. So as usual, everybody, our in case you missed it slide here, the hot links to some of the recent documents of interest. You will be able to click on these links once we send out the PowerPoint presentation later this week. And take note, we added for CDC the long-term care facilities preparedness checklist, and for 9/18 the overview of testing for COVID-19.
All right. Thank you, Jason. Do we have any more questions before we end this call today? We're actually right on time.
We are all caught up on the questions, Melinda.
Excellent. Thank you so much for participating today in the call. We plan to do this again next week, same time, same place. Thank you, everyone, and good luck with visitation. Please do not hesitate to contact FSLA if you run into any problems or if you have any questions. Thank you.
Thank you, Brian. Thank you, Melinda.
You're quite welcome. Take care, everyone.
Thanks.